Good morning. My name is Alfredo Hoyos. We're going to talk a little bit about the future of plastic surgery, specifically the future of body training. In our lifetimes, we're actually living in a very wonderful time, sir. I know you saw the Dead Zones when you were little. You were too young, maybe you're not. I saw the Dead Zones when I was little. Maybe you're millennials, you don't know about that, but they had robots, and they have hyperloops, and they had things that we didn't think in some point here, in some point maybe 10 years ago. He said, you think it's not going to happen in our lifetime. So they're having a robot butler or having flying cars. I think it's going to happen in our lifetimes. We are going to have a flying car in our life. We're going to discover the cure for cancer and aging. In fact, they're saying that the first person that is going to live 1,000 years was already born. That's what the futurologists say. And what happens with body contouring and plastic surgeon? We cannot solve three main problems. These are the three main problems that we have. The three body problems. We have shape, skin laxity, and so what? Are we say that we cured all of them? Yes and no, right? Okay. So let's talk about shape. And there's some shape. One of the advancements that happened in the last maybe 15 years was the advent of high definition as a mainstream in terms of body training. But it actually has to be not only about taking out fat, but also taking fat in some places. And specifically, the concept that we denominate the total graft. And mainly is studying almost every single muscle in anatomy and seeing the viability, safety, the efficacy, and how are going to be the mechanisms make it in terms of volume and the long run retention of this fat. Well, we're going to see a little bit of our calves. We're going to see a little bit of what we call the bar to waist. Do you know this term?
Yes.
Okay, good. Okay, so we all know about this term, and it's about the last frontier. It's literally remodeling the osteochondral structure of a person. Will it be possible? Yes. And actually, we have added, in the last 3 years, we have added a lot of science to back up these new techniques. What we can say right now is safe, it's effective. So right now, anybody can have a bar waist. The essence of that is one of the things that we call the parallel techniques. The parallel techniques are based on using ultrasound needles with ultrasonic guidance and doing a parallel access to the rib and doing what we call a realistic fracture, or actually we bend them in. Let's go to skin laxity. And this is going to be our field today. And it's what happens with all the devices that we know about skin retraction. Do they work? Can actually we predict in a very objective way to actually promise something to the patient, actually deliver it? To say, okay, if you have this amount of tension in your skin, and you have this X amount of latitude, let's say 10 centimeters of skin laxity. Can I go with a tummy tuck, or can I tell her, okay, this device is going to make it? Can we promise that right nowadays? Not really. No, but we are very close. Don't worry. We're very close from closer. And nowadays, what we can say is most of the devices for skin retraction, they can save us some spot. Sometimes this patient that was for a mini tummy tuck turned into a patient that is just for a liposuction with skin retraction technology. And maybe a full tummy tuck became a mini tummy tuck. That's what we can say now. And for that, this is a new device that is called Quantum. Quantum is actually my invention, is my patent, and it's a fully internal bipolar radiofrequency. What are the advantages? We're going to see that in depth this afternoon. But the main idea is to combine everything that worked in the previous generations of skin retraction technologies and taking away the things that are becoming adverse effects. So the idea is to generate something that actually has the best of both worlds. And in terms of cellulite, Ideas that we have something that is even for non-invasive technologies, that is cellulite, is layer particles. But what about if we can cure cellulite? Can we actually do something about it? Can we actually promise the patient that she's going to have better results and have literally resected in 100%? So yes and no, because it's not only about resecting or cutting these retinacular cutis from the skin. It's also about the different pathologies that happen around the cellulite. There is also meaning that we have to combine it with other stuff, with skin retraction. So what we're doing nowadays is we're doing a study that actually combines Aveli. You know what Aveli is? Okay, we're going to talk about that. But it's mainly a mechanical device. It's a single-use device that literally is a hook. So actually, it's like an harpoon that you just release and cuts mechanically, one by one, these attachments. But on the other side, when we do that, we actually leave the patient with a lot of skin laxity. So the idea is to combine it with our technologies. Specifically, we combine it with Morpheus and with Quantum. So this is what you're going to talk today. Let's better just show you a little bit of what we have been working on. Mainly the first one is the concept of autograft. What is the autograft concept? Anyway, we have been publishing a lot of articles about the subject, but mainly this was the one who started it. We started in 2015. We were doing fat grafting inside the muscles, specifically pectorals, deltoids, biceps, triceps. Since 2008, we actually proved that it was efficient, that it was safe, and it was effective. But in 2015, all the fuss started around the deaths of liposuction combined with fat grafting in gluten. So from then on, we actually had to go back to square one and literally go muscle by muscle. He studied all the muscles and gaining biomechanics, getting mainly what is the vascularization, the axis of the muscles. So how we base this? We started to apply this concept of high definition that literally is doing some shadows and creating some lights around the superficial anatomy. So you're literally showing the muscles and the bones through the skin, right? Very easy. And we can do differential kinds of degrees. So in blue, the basic one, in yellow, the moderate, and in red, the extreme. So we can do different degrees of definition. And with that, we're going to differentiate what happens with a woman versus a man. And in women, we start with a concept, we call it the UFEM concept. The UFEM is that we combine in some areas to do some muscularization, but in other areas, what we consider is the concept of the facets. The facets, imagine a diamond, because women are diamonds. And the diamonds actually have some facets that actually reflect the light in different ways. So the idea is to create that in some specific areas, specifically in the back. In the back, we don't want to have a lot of muscularization in women. So that's the main one, the area that we actually touch this. But the other one is the abdomen. The abdomen also has these facets that actually create these curvatures, actually create a nice feature. And that concept can be applied also to correcting the musculature. So for instance here, if you have a diastasis, we are going to correct it in a way that we restore the facets. So having said that, we actually need some muscularization as well. So for instance, in this patient, we did camouflage surgery. So we did asymmetric liposuction. She had a scoliosis. So we did recontouring. We did 4 on one side, 2 on the other side, to actually centralize a little bit more the image of having a more symmetric back. And we did quantum here. Take a look at it starts to say the difference in terms of repression step. So we talked about this concept of variable definition. We need to agree that we have different concepts also in men versus women. And we actually start with a very shapy, almost no definition, to something that actually shows a little bit more of the abs and obliques or a full six-pack. In men, any that we can do, the better, right? So the concept of UFM is combining the liposuction with fat grafting in certain specific areas. Specifically here, we're going to do it in the rectus abdominis, internal oblique. We do it always with ultrasonic guidance. And also performing in some of the areas that are not really muscle, for instance, bone structures. This is what we call the bikini bridge. So the two articles are already in production. You already accepted one of the bikini bridge and one of the VFM concept. And the idea is to create something that looks more appealing, more feminine, at the same time that looks more fit. So it doesn't look ultra masculine when we do this. So the idea is that we pass from something like this, to see, she's skinny, nice, but something that looks more athletic, with it rib contouring on her as well. So we do fat grafting as well. In men, the more muscles, the better, right? Easy. In men, we are going to divide the muscles in two series. One that we call the power muscles. So the more body we can achieve, the better. And the other ones that we consider the definition muscles. So the upper torso muscles are going to be power muscles. Pectoralis, biceps, triceps, deltoids. And in the back, mainly two, that is the latissimus dorsi and the trapezius. So those are the ones that are actually considered that increase the V shape that we want to achieve. But we start by doing liposuction, regular liposuction. We do base roll all the time. And we actually do the extraction. And we start doing these negative spaces here and there. Once we do these negative spaces, the idea is that we finalize to doing some definition. And later, we do the fat graft. So this is more or less what we do, as you can see. This is one of the patients that we do in the courses. So once we finish, we have done in this guy, rectus abdominis med grafting, obliques, pectoralis, biceps, triceps, deltoids, latissimus dorsi, trapezius, and the buttocks. So we can say this is the same guy 24 hours later. So this is the Mikhail report. 2 months later, 1 year later. The results get retained over time. But the concept is a little bit more complex because we need to say, we are going to literally shift the volume from one side to the other. When we do these kind of cases, there is very little fat that we throw away into a can. We put literally recycle muscle fat or green oriented. We started with this one that is the pectoralis. We did the first 2 articles in 2012 and 2018. And the same conception actually happens for every muscle. So what we had to realize is, okay, what is the shape of the muscle? This is a pentagon. So we contract, actually gets all the fibers inwards and upwards, right? But also, what happens with the vascularization? The main vascularization is acromial here and the perforance in the middle. Do we have any other conceptions here that we need to know? Yes, I think the axis. So the axillary axis is easier. If we actually do it from the nipple, it's going to be actually against the rib cage. So the idea that we need to analyze all these concepts in order to achieve it. So one of the features is that we started to do it, polante, because there are muscles that doesn't need to have a full ultrasonic guidance. There are others that need it all the time. So we are working in classification around that, the safety versus the ultrasonic flattens that we need. So these are type 1, because it's a muscle that we can, when we grab it by the hand, we can grab the full muscle and we can even grasp behind the muscle. So we have this full grasp power. We actually have a very safe way to access the muscle. And nowadays, we started to do it with ultrasound as well. So we consider that there are 3 kinds of muscles. One that need to have previous, so before getting the cannula in, to actually pinpoint where the vascularization is, where are anatomical features that we need to pinpoint. This difference is the one that actually just for checking that we are in the right spot. So this is the pectoralis. And the third one, we call it the A to Z. The A to Z is that we need to have the ultrasonic guidance before entering, when the cannula enters, during the entrance of the fat, and on the way out. So this is the rectus abdominis, for instance. So this is the patient that we did on the table. This is 48 hours later. And actually worse with other things. For instance, here with his fat grafting, liposuction, and skin reproduction knowledge. So this guy was the perfect candidate for doing a full lipectomy in the pectoralis, and we are saving scar because the scar is right here, goes hidden inside, etc. So can we say that we can achieve that with this combination of things? Because what about it is also the fat grafting. Fat grafting is cooling up and expanding the tissue, so actually gain some of the skin that we were going to resect. Deltoids, and one of the curious things is, I'm going to show you just a little bit, just to show you things. If we actually access the deltoid from the anterior unit, there are a little bit of cables here that are in the middle, and it's not socially well accepted to actually damage one of them. No? So the idea in this case is that we are not going to use the anterior axis there. You think what we need to use is the posterior axis. And we have, when we did all the dissection, we did dissection in every single muscle we studied. And one of the features is this. If we actually go anterior, actually we go in this branch, that is the anterior arteries, and we go in the same direction that we're going to inject the fat. We go from the posterior, a branch that is circumflex, is actually in the surgical neck of the humerus. So it's very low compared to the area that we are going to achieve for the main target area. So it's actually beyond the area of the scope, right? So that's how we actually analyze every muscle. So for instance, here in the deltoid, they just do it in prone. So the patient is actually lying down, lying prone. We actually pinpoint that the muscle is in place. You actually affix the cannula, so we penetrate in the posterior border. And this is more or less what we achieve. Now, the third problem is, how much can we inject? So for instance, what we decided here is 50 to 100 cc's one, because more is 150, already starts looking a little bit upward. So the idea is to get just the perfect matching, and also to don't increase the pressure inside the compartment enough to have the patient have no problem. Right? So we analyze every single muscle and doing the anatomy and the axis as well. So for instance, here in the biceps, we actually need to go subcutaneous over the tendon and penetrate the muscle in the middle third. That's the easiest way and the most safest way to work. The triceps, we're going to work it for the two sides. We're going to work the distal incision. We're doing the long head. And from the axillary to do the transverse or lateral. So why is this important? Because when we are actually crossing through transverse or lateral cat, we are actually underneath it. We have the radial nerve. So if we actually increase the pressure there, you actually can have a compression center. So in this specific case, it's better to do it with ultrasaturated. So that's how we came to the classification. And beyond, so the idea that we started working with several muscles, we actually do most of the muscles at once, and are reading biceps, triceps, deltoids. Depending on what we need, we actually achieve another types of small muscles, for instance, the upper obliques and the serratus muscles, the latissimus dorsi muscle. I do it actually from supine. It's a back muscle, but we use a supine position because it's easier. And so on. So the idea is, with that in mind, we can say that we more or less achieve a good definition with fat grafting. This is a long way. This is 6 years after the surgery. So the patients retain the body and retain the results in the long run. The final frontier, the reps. So we already published this year, early this year, this book about what we know about the rep comparing. Well, we started with techniques that are posterior, They were designed in Russia. This is not our idea. They're actually during COVID, I started to hear, I worked in Barcelona, so I was doing surgery. It's too bad that we cannot do anything here. and there was a resident that was from Moscow. And she told me, like, there is this guy in Moscow that does this surgery about the ribs. And literally, it's like, for us, it's like talking about Sasquatch, you know? Same thing, you know, because the rib surgery is kind of a myth, you know? We say that everybody says, oh, Sherry had the rib removed. And, you know, every time that a patient comes to us and says, oh, I want the waistline of Thalia or chair, we say, oh, that doesn't exist. It's an urban myth, doesn't exist. So we follow to the source, and what we discovered is a very interesting technique, because what we debilitate the cortical and do literally bring stick fracture. Where? 8 centimeters lateral to the ischimus muscle to actually bend. And we actually bend usually 10, 11, and 12. Can go up to 9 if we want, but the idea is to create a different shape. You know, what we couldn't achieve with other methods before. And we combine it with high definition, we combine it specifically in lady. You're a lady patient, there is nothing you can do with liposuctions, no lights. So that creates what we call the last frontier. In the frontier, we couldn't touch it, no. And even we were finding it complete anterior, it's called powerful, but we were finding very young. But this is the patient, because looks very childish. She doesn't look like a woman. Looks like a little girl. She wants to become more feminine. So it's something we couldn't achieve with other ways before. So with this in mind, we're gonna go back to the OR. Thank you very much for your attention.